Good afternoon. I'd like to welcome you to today's Medical Center Hour, a program entitled Every Patient Tells a Story. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we bring you these weekly Medical Center Hour programs. The program this week is something of a special event, the medical school's Koppaka v. Rao lecture in the medical humanities. For several years now, the Koppaka Family Foundation has funded this annual lecture, which was established with an eye toward improving patient care and improving health professionals' communication with patients and with their families. UVA is one of many medical schools in the U.S. to receive Koppaka Family Foundation funds. A little bit of background. Mrs. Sita K. Rao established the foundation a little more than 10 years ago in loving memory of her husband, Dr. Koppaka V. Rao. He was a medicinal chemist who rose from impoverished beginnings in a small village in India to earn advanced degrees in science. He emigrated to the U.S., where he had a rich and productive career both in pharmaceutical research, he worked for Pfizer, and in teaching pharmacy students at the University of Florida. He loved his work and believed passionately in scientific discovery, in teaching, and in being a good human being. This gentle and accomplished man and his wife raised 3 children, and 2 of them, Jaya Rao and Ram Koppaka, became physicians. Dr. Jaya Rao did her internal medicine training here at UVA. She's recently become a full-time associate editor of the Annals of Internal Medicine, and her very recent move to this new post and relocation to Philadelphia meant that she was unable to join us here today. Dr. Koppaka Rao's last illness was so tragically troubling for his family that in 2002, his 2 physician children wrote an impassioned piece for the Annals of Internal Medicine about how their father's doctor's communication with the family could have, maybe we should say, should have been better. Basically, there was no good communication. And the young doctors in their essay contended that those same doctors could have cared better for their father and for the family had they known more about their patient as a person. One physician out of many provided compassionate advocacy, and that made a big difference. But except for him, the son and daughter, in their own words, quote, longed for a physician who knew our father as more than just another case. We're delighted to welcome today physician author Lisa Sanders, who is an assistant professor of medicine at Yale University School of Medicine and a clinician educator in the primary care medicine residency program there. She's better known to many of us as author of the 2010 book, Every Patient Tells a Story, and UVA bookstore is here outside the upstairs entrance with copies of the paperback of that book, and Lisa will happily sign books after the program. She also writes 2 enormously popular medical features for the New York Times, Diagnosis and Think Like a Doctor. And her writing inspired the long-running television series House. Now there's a paragon of communication. And she served as a technical advisor throughout the television show's run. With us today, she'll probe the crucial communicative exchanges between doctor and patient, the stories that are at the heart of every medical mystery and its solution, and at the heart of good ethical practice. So much depends upon these stories and on the medical rituals of their sharing. I will also let you know that Dr. Sanders has declared no financial conflicts of interest. And so welcome, Lisa Sanders, and we're looking forward to an interesting
No conflicts. If anybody wants to find me a sponsor who will pay me money to talk about the things that I like to talk about, I'm happy to have a conflict, but I don't. Thank you for that very generous introduction. And it's really an incredible honor to be asked to come here and to speak in this forum. I think that talking to patients, doctor-patient communication, is really the heart of what is missing now. of so much of medicine and so much of what we teach our doctors to do, that I'm thrilled to be able to talk to people about this thing that I care about. It's named for somebody who suffered the way so many, too many of our patients suffer. So, as Marcia said, medicine is my second career. When I was before, I was a television news producer, and I covered medicine. And I thought I understood what medicine was from covering it. This is the arrogance of journalism. We feel like from the outside, we can tell what's happening on the inside. But I didn't know anything about the kind of story that I think is most important until I was a third-year medical student. So I don't know how they do it in medical schools here, and many of you don't either, but I'll tell you that in my medical school, you spend the first 2 years in a classroom, PTSD similar to this, for 2 years, listening to doctors talk about their things. Okay, we did leave to go to the anatomy lab. That was really cool. But most of the time, we were in a room like this, and then the third year, we actually get to see patients, and we're loosed on the wards. And that's a very, very exciting moment. One of my first rotations was on medicine. And at 10 o'clock, everybody stopped what they were doing, came to a room with a table in the middle of it. The residents sat around the table, and all the old doctors who came and all the medical students who came sat around the periphery. And then one resident started telling the story of a patient that they had seen. I'd never heard a story like this before. They start with the chief complaint, and went through the history of the presenting illness. And if you've never gone to one of these, you don't know, but this is called resident report. And it's a meeting that happens every day, most places, 6 days a week, some places. And it's like a little detective story is unraveled right in front of your eyes. And you, with the doctors, figure out what's going on. It really made an incredible impression on me. And after that day, the thought of doing anything besides going into medicine was inconceivable. So when I finished my medical school and residency and started my position at faculty, I got a call from a friend of mine who had, since I saw him last, become an editor at the New York Times Magazine. And he said, you know those stories you're always telling about these little detective stories about, these weird patients that you see? I'm like, yeah. He said, you think that would make a feature in the paper? I said, no. But fortunately, I was wrong. So I've gotten to do this fantastic and fun thing for the last 12 years. I write about this story. And since in the last 2 years, I've gotten to write in Tara Parker Pope's blog called Well, I write something called Think Like a Doctor. And I think this is so much fun. I tell a story including all the lab results, all the studies that were done, and I post it all, because it's the internet, you have as much room as you want. Right up until the point where the doctor makes the diagnosis, and then I stop. And I say, what do you think it is? And hundreds of people write in, it's crazy. Okay, a lot of them are doctors. But you know what? A lot of them are not doctors. And I find it very interesting. I love reading what people think and how they're sort of dealing with this information. It's very cool. And the next day I explain what the diagnosis was. Although I'm thinking about doing one without a diagnosis, if anybody has any interesting cases that they want to let me try on my Well site. And I took those stories and I gave them to this guy. As a brain, it was worth it, but as a guy, what a jerk. When I got a call from this show, so they had used my column sort of as the format for the show, and they had used one of the executive producers, David Shore's personality for the character. So after they got the pilot approved and they got the okay from Fox, they called me and said, you want to, work on our show? I'm like, well, what's it about? And Paul Adanasio, who was the co-creator, said, well, it's about a doctor who is arrogant and irritable and drug-addled, who hates patients and loves diagnosis. In my mind, I'm thinking, that's never going to work. Who would watch that? But of course, I didn't say that. I said, wow, that sounds fascinating. Sign me up. And it turns out, well, as soon as I saw the pilot and I saw Hugh, I knew it was going to work. Because even though he personifies everything I hate most about doctors, I'll get more specific in a minute. You know, something about when you look in his eyes, you feel like inside this very deep, hard, very crusty shell, there's a caring, compassionate fellow. I don't know how he sort of projects that duality. That's just how great he is as an actor. But I thought, okay, I get it. But of course, House is not accurate. I don't know if any of you have ever been in a hospital, but you know, in most hospitals, there are a lot more doctors, there are a lot more nurses and clerks and technicians in every hospital I've ever been in than there are in-house. In-house, doctors run all the tests. Do you know what would happen to me if I tried to get a CT scan on my own patient? Are you kidding? I don't even know what the buttons mean. It's crazy. In-house, internist performs surgery. Look at this guy. He doesn't even have a mask on. He's just breathing into this guy's viscera. Even brain surgery. Okay, let me just point out, you see that girl? She's an internist. That guy there, he's a plastic surgeon. Doing brain surgery. But that's, you know, that's just the liberty you can take when you're dealing with fiction. And they didn't promise to be accurate. I don't think there's very much that promises accuracy. You know, people used to ask me, you know, if I thought that, you know, this was a bad influence on medical students who were going to act like this guy when they see patients. And I said, anybody who acts like this guy because they saw him on television should be drummed out of the court. Please. Anybody who thinks that they should do what they see on television, they're idiots. They shouldn't be doctors. You know, there's a whole school of internet things about dumb things that people do. Nobody's worried about those people being imitated. So I don't think that that's the real risk. I do think that the real risk for this show is that it completely obscures the process that the show is devoted to. In some ways, it really tries to reflect the diagnostic process. I mean, you know, they sit around, they create a differential diagnosis, they try to think through how this disease would look, why it is likely or less likely given who the patient is. I mean, in some ways, they do try to think like a doctor, but they don't value the data that goes into that whole thought process. Where does that data come from? Well, honey, it comes from the patient. That's where we start. So, you know, I have mixed feelings. I loved Hugh. I loved that this show loved diagnosis. But I was really ticked off that he was such a jerk. You know, he didn't value, or he said he didn't value the patient's story. I mean, one of his most famous lines, it was from his first show, he says, "Everybody lies." And my feeling is, honey, everybody lies to you, because you're a jerk. I wouldn't tell him anything. But I don't think that everybody lies. In fact, I think that the patient's story is an important part of every component of medicine. It's an important part of compassionate care. You know, not just the story of their illness, but their bigger story and how this all works. Because illness does not just take over a small part of you. It takes over all of you. So I think it's important for compassionate care. I think it's important for therapy, and I'll talk about that in a minute. I think it's important because it's good for the relationship between the doctor and the patient. And that's often the way it's sold to medical students is, if you listen to your patient, you will have a better relationship. And that's true. But you know what that doesn't do? Is it doesn't value the other thing that the patient's story is important for. This is the data that we work with. We augment it with other data, but fundamentally, the patient story is all we have because there is no test that can tell you how that patient feels, only themselves. And really, we depend on that story to make a diagnosis. For me, this is how diagnosis works. The patient takes their story and they give it to the doctor. The doctor tries to manipulate the story, takes away stuff that they think are not relevant, adds other things that they think are relevant. I don't know if you've ever read a doctor's account of an appointment that you might have had for a summary of your case, but it's almost unrecognizable. 37-year-old woman, 37-year-old right-handed lawyer comes in, you hardly recognize what they're talking about, who they're talking about, because it's all stripped down. But that's what has to happen to make a diagnosis, I do think. And then, and this is a part that we hardly ever talk about, which is one of the sources of this talk to begin with, is we as doctors have to learn how to give the story back to the patient. Because it's their story, and because they're the people who have to live with what we found. So, a long time ago, at the turn of the 20th century, William Osler told us what we already knew. Listen to the patient, he will tell you the diagnosis. It's been part of what we have known in medicine for a long time, but it was never tested until many years later. In the 1970s, 5 doctors in England decided to find out whether that was true. Find out what was the most important component of what happened between the doctor and the patient that led to a diagnosis. So 5 doctors in 5 different practices in England saw 80 consecutive patients, a total of 80 consecutive patients who presented without a diagnosis. And each doctor recorded their differential diagnosis after each step of the evaluation, after the history, after the physical exam, after the test results came back. William Osler would not be surprised to know that the correct diagnosis was made most of the time after the history, after an adequate history was taken. The physical exam, which I love, was modestly effective. How about this? Testing, 9%. No better than the physical exam, which of course is another kind of test. So the history turns out to be very important. Now you might say, my mother wasn't even born in 1975. I mean, nothing that was true in 1975 is true now. Why would you expect this to still be true? So, you were not alone in thinking that. So another generation of doctors decided to repeat this experiment. In the 90s, 4 physicians in Utah reproduced this experiment as closely as they could. What they found was the same, that history was the most important part of making a diagnosis, and that physical exam and testing were useful tools, but they were adjuncts. 1992. Many of you in this room were not born in 1992, so that is also a really long time ago. And I wish that I could say that somebody recently had replicated this study, because I think it would be an important thing to do, but that would be a lie. As far as I know, it has not been replicated. There was something close. There was a study that was set up to check senior residents versus hospitalists in evaluating new patients. And so they tried to reproduce this in some ways, looking at history alone, the physical exam alone, the basic tests alone, then history and physical together, and they combined them in various combinations. And what you see is that the history alone wasn't that useful. I don't know why that is. I have my suspicions, but I don't know why that is. But when you combine the history and the physical exam, the physical exam by itself was pathetic. You see, 3 patients in one group, 2 patients in the other group, based on the physical exam alone. But when you combine somehow the talking and the touching, you got a much better result. So 40% of the time, the diagnosis was made by the history and the physical exam alone. House is fiction, but we try to touch on the truth every now and then. For larks, after the first few seasons, I went through and looked at all the House episodes and did an evaluation of the first 3 seasons to see what key piece of data triggered the diagnosis. And 60% of the time, the correct diagnoses were based on history. So some of that is the requirements of drama. If it was some obscure little test, it would be very hard to explain. But I think there's also a sense that this is right. This is where much of the information needed to make a diagnosis come from. It's from talking to the patient. Well, since everybody, even House, believes this to be true, if he doesn't say it, at least they acts it, then, doctors must obviously really, really value the time that they spend one-on-one with the patient. I'm sure that in your own experience that has been the case. Well, not so much, as you all know. Fewer than a third of the patients in studies, so they did this study where doctor and patient both knew they were being looked at, they weren't told why, and then they just listened to tapes of these encounters. And in fewer than a third were patients allowed to actually tell their story. When they were allowed to start telling their story, they were allowed to speak for an average of 23 seconds before the doctor interrupted with a question. Some doctors only waited 3 seconds. I think that's for the person who comes in and says, I have chest pain. Then you interrupt. But it seems like it's not much of a story if you only hear 3 seconds of it. Once interrupted, the vast majority of patients don't continue their story. And this totally makes sense. Patients don't come in knowing how this is going to go down. They expect doctors to give them signals about what kind of information is important. If you interrupt them and start asking these yes, no, or very narrow questions, they're going to think just the facts is what you want. And what you're going to get is just the facts, ma'am. You're going to get yes or no. They're going to let you ask as many questions as you want. This has consequences. When the doctor is in charge of getting all the data about something he really doesn't know about because he hasn't let the patient tell the story, it's not going to be perfect, often. And when interviewed after a doctor-patient encounter, often doctors and patients did not agree what happened in that encounter and what that encounter was about. And most patients said that they had problems that they didn't get to address in any way. That has consequences. That lack of communication. And Hardeep Singh just did a very nice study looking at errors committed in a primary care setting and found that 60% of the errors happened in that doctor-patient encounter in the talking part of it. 80% of it happened in that office. Of that, 56% of all the errors were made because of an insufficient data collection. Okay, so why are we so rotten at getting the patient's story, since we all know how important it is? Well, of course, time is a huge part of this. We really don't have time, and we have allowed ourselves to be boxed into schedules that really don't give us enough time. And that is not new in some ways, and much worse recently. So the average in-office doctor visit lasts between 10 and 15 minutes, depending on how you measure it. And that's different. In 2001, it was measured at 21 minutes. So it's, it's much, much shorter than it used to be. Let me just tell you how these two numbers came, and you can decide which one you think is closer. 10 minutes, which is half the time we used to spend with patients just a decade ago, or if it's 15 minutes, which is not great, but a little closer. So 15 minutes, doctors were given the job of writing down where they were every minute. They carried this clipboard, and when they went in to see a patient, they wrote down the time. When they came out of that patient's room, they wrote down the time. When they went to the bathroom, they wrote down the time. Everything they did was documented. And that's a pretty good way to find out where people are, is to get them to write it down in real time. Here's a better way. There was a video camera in the patient's room. And that video camera showed that doctors spent about 10.7 minutes on average in that room with the patient. Now, that's not, to be fair to doctors, that is not the amount of time they spent with the patient here. Before they went in to see the patient, they're going through their chart notes to make sure that they cover the things, that they follow up on the things that were touched on the last time, that to remind themselves what the problem was the last time the patient visited. So that is time spent with the patient in some ways, but it's not time spent getting the patient's story. And that's what I'm talking about. Given this very significant time limitation, I think the doctors would want to spend time with patients, and I think that that kind of hairy, crazed look they sometimes have when they come into the exam room comes because they feel this time pressure. But you might think that given this time pressure, doctors can't really afford to take the time to give patients the floor and say, tell me what brings you in, and just let them gas on for God knows how long about whatever it is that's bringing them in. Well, people have actually measured how long patients talk when they're given an open-ended question like that and don't get any cues that it's time to wrap it up. And in general, most stories last 60 seconds. That's the average. And none of the stories lasted longer than 150 seconds in this study that was done a long time ago. It was a good study. So it's hard to say that you don't even have one extra minute to listen to the patient. If you worry that the doctor appointment might last too long, it's true, they did last about a minute longer. So we feel this time pressure. We often communicate this time pressure to our patients, and patients often feel like they're in a hurry to get things out, to get things done. They want to be the most efficient they can be. And they trust the doctor that, this Q&A is the best way to do it. I don't know that that is the case. And I want to tell you a story about a patient of mine that I think shows what happens often. And what Hardeep Singh in his study, showing that it's the doctor-patient. Now that was done in the office, and I'm going to tell you a story about it in an emergency room, but that it's that encounter and the loss of data in that encounter that leads to most diagnostic errors. So Charlie was a patient of mine, is a patient of mine. When this happened, he was 65 years old. He had never been to a doctor. He would have proudly told you right up until the year before when he had a massive stroke. And since then, he had been a very good patient. Took his medicines, came to his appointment, and was just unbelievably wonderful and was one of our favorite patients, and still is, I must say. One day, he came in to see the nurse. I was out of town. And as soon as he walked in the door, the secretary noticed that he did not look right. He was a guy who had had a stroke, a massive stroke, and so he walked with a cane, and he spoke very slowly. His face was droopy on one side, so he spoke with a little bit of a slurred speech. This was a couple of years before, and he had gotten a lot of way with his physical therapy. But this day he came in, and he was bent almost over like an old man. leaning on his cane almost, and he was walking really slowly. So the secretary hurried to get the nurse and brought her out to the to the waiting room, and she helped Charlie sit down in a chair, and she took his pulse. She said, "What's the matter?" And he said, "I don't feel right." And his pulse was also really, really slow. And she was, as we all would be, appropriately scared. So she sent him to the emergency room. In the emergency room, he was seen by a friend of mine who's a wonderful emergency room doctor. And this guy, Bernard, said that he did his best to take a history, and I'm sure he did, but you can imagine this guy speaking at the speed of glaciers melting, back when glaciers used to melt slowly, in a busy, noisy emergency room. He also was hooked up to a monitor, so that he had this like flat line with a little boop, boop, reminding you that this guy was dying in front of your eyes. And so I suspect that an adequate history may not have been taken. It wasn't there long before they decided to send him to the cath lab to get a temporary pacemaker placed. I come from Connecticut. Basically, if you don't have a story of a Lyme disease, that's an excellent chance you're going to get a temporary pacemaker. Lyme disease is probably the only indication when you have a heart rate like that where you don't get something like that. So I was in the cath lab, and they were about to, make their first little incision to put in the pacemaker when the phone rang, and it was the lab. And they said, "We have an explanation for why this guy's heart is so slow. His potassium is 8. So potassium is this really key chemical in your blood that is important for muscle function. When you have too little of it, your muscles are too twitchy. When you have too much of it, as he did, twice as much as he should have, your muscles don't work very well at all." And so why did he have potassium of 8? Well, the lab had an answer for that. His creatinine was also 8. So creatinine should be in the neighborhood of 1. Creatinine is not anything bad for you, but it's the way we check how your kidneys are working. An 8 means that your kidneys are not working at all. And so the cardiologist thought, well, he does not need a pacemaker, because all we have to do is get his potassium down. And they just sent him up to the ICU. They gave him some medicine that will help him get rid of the potassium, and they sent him up to the ICU to be observed. In the ICU, he was evaluated by the nurse and the intern on call then, on duty then, and then examined. And then the intern did what we all like to do best, sat down with the chart to really examine the patient. He noticed that in all of the mini tests that this guy had, nobody had gotten any urine. If your kidney is not working, then urine is often very instrumental in figuring out what's wrong with the kidney. And so he asked the nurse to please get a urine sample. So she came back about 45 minutes later, empty-handed. She said, "I absolutely could not get any urine. Moreover, he told me that he hadn't been able to pass any urine for over a day." So she didn't get the urine, but she didn't get the answer. So he had something that's very common. He had benign prostatic hyperplasia. After age 50 or so, men who have prostates, which is that gland that's around the urethra, their prostate tends to get larger. Sometimes it gets larger in such a way that makes it hard for urine to get through the tube that leads from the bladder to the outside world. In Charlie's case, it completely closed off the urethra. So they got the urology resident in, the urology resident with a combination of charm and skill managed to pass a catheter into his bladder. They have these little basins that are for collecting the urine that come out of the bladder, and they hold, I don't know, 500 cc's or so. He totally overflowed it, and their best guess was that there was about a gallon in there, which is a lot. That's a lot. So when I came back into town, he did fine. He got a TURP, transurethral resection, which opened up everything, and he's fine. Still having a stroke, still walks with a cane, but he pees, and that's the most important part. When I got home from being out of town, I heard the secretary told me, "Your patient just about died right here in the office." And I'm like, wow, that is not an overstatement, I would say. Heart rate of 30 when you walk in, you can die. So I went over to the hospital and I sat down with this chart to just try and figure out what had happened. On the very first page, the triage nurse, who was the first person you see when you come in, had written down, "Patient says he has not been able to pass any urine in over a day." So when you take a history, it's important to ask, as I suspect this triage nurse asked, why are you here? And when Bernard, my friend who in the emergency room saw him, I don't think he asked that question. I think he said, "What medicines are you on? Do you have any chest pain? Are you short of breath?" If he had asked the right question, he would have gotten the right answer. Now, let me just say, nothing bad happened to Charlie. They figured it out. He got his TURP. He works just fine. But there were 8 really unpleasant hours that might have been avoided completely. The patient's story turns out to be extremely important. So I hope that and time saving. Can I just say time saving? So we don't have enough time. That's a given. Why else might we miss the story? Well, I think we're not really trained how to do it. Now, in 2004, they passed a regulation that said that in order to pass your boards, you had to show that you knew how to interview and examine a patient. It was part of an exam. Perhaps that was effective. As it turned out, 99% of all doctors turned out to be a whiz at taking a history and doing the physical exam. That does not correspond very well with my own experience of residents. But that's what the test showed. So I don't think it's a very efficient, I don't think it's a very effective test at measuring what really counts. I think that what they really measure is that you know which way is up and that you speak English. 2 very, very fundamental and important components to being a doctor, but certainly not enough. But I don't think we're taught how to talk. I know we are not taught how to listen. I had a head start on this when I was a television producer. I would get sent out to do an interview with some news guy. And I would sit there. Correspondents do not go out and do interviews. Their time is way too valuable. So I would go out and do this interview. And the interview would happen in 2 ways, or 2 things were going on. I would be having this conversation with the person, good eye contact, nodding, so that they don't think you're falling asleep in their answers. But the other half of my brain is going, does that make sense? Do I understand what he's saying? Is this what I need for my story? Is this the best he can do? And then you turn off the tape machine, you turn off the camera, and you go home, back to your studio. And if you missed it, everybody will know because it'll be on the other network. So you learn very quickly how to do an interview where you get the component parts. Nobody teaches that to residents or to medical students or to doctors. And so it's just like you talking to your aunt and listening to her talk about her bad knees. Maybe you're paying attention and maybe you're not. Maybe you think it's interesting. Possibly you don't. So we don't teach people how to do this, but we expect them to know how to do it. And some people do, but some people don't. Another reason I think doctors miss the story is because they're uncomfortable with patients' emotion. Now I have to say that when a patient cries, absolutely it's going to throw my schedule off for 15 minutes, no question. You just can't get somebody out of your office when they're crying in less time than that. or I haven't been able to. But you still got to go there. You still have to do it because it's important and because patients need, because being sick is very upsetting. Being sick has a lot of meaning to people, meaning that you don't even think about, meaning that's far beyond whatever discomfort people have with this illness. I mean, being sick is has a lot of different kinds of meaning to people, and you will never know what it means to this person if you don't let them tell you. So I want to tell you about a friend. This is not a patient of mine. He was a friend, and still is. Dan moved to New Haven, Connecticut, where I live, from California. And he called me. He had just moved there weeks before. His family had not come with him. He was staying in an apartment until they could get everything set up. And he called me and he said, I'm wondering if you could prescribe me an albuterol inhaler. I had asthma as a kid and I think it's back. I said, really? That's weird. Tell me about it. He said, well, I walk from my apartment to class every day, and there's this hill, and at the top of the hill there is this orchard, which is in full flower. When I get up to the top of the hill, I have this tightness in my chest, and it's really, really hard to breathe. It feels just like my asthma, except it's funny, but I'm not really wheezing. So it occurred to me, as it probably has occurred to everybody in this room, that does not sound like asthma at all. And in a 55-year-old guy who has exertional shortness of breath, the chance that this is asthma is pretty small. So I explained that I thought that perhaps this was not asthma, and that maybe what he really needed was a cardiologist. And he said, no! My father died at 55 from a massive heart attack, and I have lived my adult life with the sole purpose of never having that happen to me. He said, I exercise every day, I don't eat meat, my blood pressure is better than yours, and so are my lipids. This cannot be heart disease. We talked about it a little more. He went to see a cardiologist. He's had a 3-vessel angioplasty, and he's just fine now. But I don't know. I'm not sure. I go back and forth about this. Did he know that this was heart disease and he called me so I could tell him that? Or did he really think it was asthma? I sort of flip-flop. The guy's a PhD. He's been thinking about heart disease his whole adult life. He told me so. I think he wanted me to know. I thought he thought I would know. But in any case, if I hadn't known, if I had been busy, this scares me too, if I had been busy or in a hurry, I could have said, sure, what's your pharmacy? I'll call it in. We can miss things. People can tell their story in certain ways because they don't want to, because it has meaning to them. And if you don't poke even just a little, it's not like I didn't sit him on the couch and ask him to tell me about his childhood. So it doesn't take much for people to tell you what's going on with them, but if you don't ask, they will certainly never tell you. So the doctor takes a story and comes up with a diagnosis. I'm not going to talk at all about that, except to say, anybody here ever Google their symptoms? Okay? I got my 11-year-old daughter. I'm a doctor. I got my 11-year-old daughter Googling her symptoms. I'm like, you could just ask me. Well, Mom, you might not know. It's true, I'm not a pediatrician. Still, she's not. 55% of patients who were surveyed after being seen in an emergency room, so they had something bad enough to send them to the emergency room. After their visit, their greatest concern was that the doctor had got it wrong. They weren't worried that they had some terrible disease. They weren't worried about the expense of taking medicines for whatever it is they had. No, they were worried that the doctor screwed it up. You know what? They were not wrong to worry. It's estimated that 15% of all the diagnoses we made in a primary care setting, and an emergency department, sadly enough, is a primary care setting, will be wrong. I talked a little bit about the study done by my friend Hardeep Singh, where he looked at where errors were in primary care, and this is his study. Most diagnostic errors, 80% of diagnostic errors, could be traced to the doctor-patient interaction. And when he looked at it, so he broke down this, the kinds of things that happen between chief complaints and making a diagnosis. And so patient-related, did the patient lie? Did the patient in some way not able to talk, comatose, whatever? So that would be a source of diagnostic error. And you might have ordered the wrong test, or the wrong test might have been done, or you might not have interpreted the test results correctly, or you might have referred them to the wrong people, or the people did not recognize what was going on, whatever. And those are all potential sources, but they're totally, totally dwarfed by that giant column in the middle, which is 80% happened in the doctor-patient encounter, and 60%, 56% of those came from inadequate data collection. So Peter Pronovost, the guy who did the checklist, he weighed in on this in JAMA in 2009, and he said up to 80,000 hospital deaths result from misdiagnoses every year. I don't know what that really means, numbers like that. It's like the Grand Canyon. It's hard to believe. It's hard to really know what to make of it, but maybe that's true. He certainly has the right credentials. So diagnostic error, it happens all the time, and most of those errors happen, at least I think, and at least in the outpatient setting, because of inadequate data collection. So that's all I'm going to talk about, the diagnostic process. I have a whole other talk about that. But now I want to talk about the last leg of this whole process, which is when the doctor gives the story, the new version of the story, the revised story, back to the patient. You know, this is what's great and terrible about being a doctor, is that really, of the two people in the room, you're the only one having any fun. You know, we get to figure things out, and there are very few things in life that are more fun than that. It's the patient who has to actually live with the disease, whatever it is. Sometimes it can be you have a broken leg, that's easy. You know, you wear a cast, it's a bummer, but you're fine. But most people who go to the doctor these days go to see a doctor not for trauma, not for some acute visit, but for some chronic condition that they have and that they have to live with, often for the rest of their lives. And it's our job as a doctor to give them that story back in the language and the ideas that allow that patient to integrate it into the already very complicated tapestry of their lives. It's not like people are waiting around for a diagnosis. No, people have jobs, have children, have lives, and they're already overbooked, overscheduled, and totally stressed. Now you're giving them this other new thing, and you have to give it to them in a way that allows it to make sense to them so that they can take it into their complicated lives and work with it. Because it's up to patients to do what needs to be done with this diagnosis, taking medicines, whatever it is. I mean, what do we ask of patients? I would say in some ways the simplest thing we ask patients to do is go to the hospital, lie in a bed, let us take care of you. Forget that we're going to wake you up at 5 o'clock in the morning and take your blood pressure and stick you with a needle and get your blood. Just relax and we'll take care of you. What could be easier than that? Nothing, right? And yet, up to 2% of patients will leave the hospital against medical advice because they don't want to do that. It's hard for me to believe that if they really understood what was going on, they wouldn't want to do that, but they're leaving the hospital. So there is, I would say, some lack. It's what Coolhand Luke gets told, a failure to communicate. And it ends up with the patient leaving the hospital. against medical advice. Sometimes they come back, sometimes they die, sometimes they do fine. But it's an easy thing to do. But a lack of a story, well delivered, makes it hard. And it's not just that patients can't stay in the hospital. They don't even like to take their medicines. You know, so most of my patients, like most of everybody's patients, they have diabetes, they have high blood pressure, they have bad cholesterol. Those are the patients who come to see their doctor most often. They have bad knees, and so I tell them, you should exercise more. You should eat this way. Here's a diet that you should follow. You should, use less sodium. Here's a list of things to avoid. But then they turn to me often enough, not 100% of the time, but often enough, they say, oh, come on, doc, don't you just have a pill you can give me? They want a pill. Well, actually, they don't want a pill. They're not taking them. Half of the people with diabetes are not taking their medicine the way I think they're taking it. Almost half with high blood pressure are not taking their pills the way I think they should be taking it. There's evidence that shows that if you gave the story back to them better, it improves medication adherence. It reduces the likelihood that you're going to get sued. It's going to make the patient recover more rapidly. That's after surgery. It reduces pain. It improves surgical outcomes. All these things have been shown. I mean, they've been studied extensively. These are just a few of the studies. Hundreds of studies have shown that if you, as a doctor, give the story back and help the patient understand what's going on and what we're doing here, adherence improves. We don't do that. But it's not just the pills that this affects. I would say that giving the story right is something that helps heal. And I'm going to end by telling you the story of a patient who is not a patient of mine. I've never met this man. But he is, I forgot to turn this on. Oh, well, too late now. He wrote to me, because I write this diagnosis column. He wrote to me while he was still in the hospital. He said, I have the most incredible story to tell you. He's a 26-year-old guy, computer programmer, lives in Boston, and he was living with his girlfriend. They were planning to get married. And suddenly he had very, very significant short-term memory loss. 26 years old. This is how bad it was. When he went on one weekend to go finalize the plans for their wedding, which they had been working on, as anybody who's gotten married knows, it takes like a year to get this all together. Been working on it for months. He couldn't remember where they were, who they were talking to, or what they were doing there. And he realized he kept asking the same question, so he just didn't say anything. And he was so relieved when he got back to his apartment in Boston, and that was over. The next morning he gets up, goes to work, gets lost on the way to work. Calls his fiancée. He said, there is something really, really wrong with me. She said, get somebody to take you to the hospital. This will tell you what year it was. So he goes to the hospital and he's diagnosed with the Ambien syndrome. Does anybody remember this? Everybody who took Ambien was forgetting things. So he was diagnosed with that, and his girlfriend was like, nah. And she said, stay where you are. She drove down. She picked him up, took him to another emergency room where he was diagnosed with what he really had, which was something called limbic encephalitis. That's very rare. It only really comes from herpes encephalitis, but he didn't have that because he'd been suffering with this for weeks. Lung cancer seemed unlikely in a non-smoker. Or what's the third thing? Lupus and other diseases like that. Well, it turns out he did have a kind of cancer in his chest. He had Hodgkin's lymphoma. He had a huge mass in his chest, which a chest x-ray showed right away. And so he started getting therapy for this. I mean, he went to the emergency room, was admitted, and started therapy pretty much days later. He wrote to me after he had been in the hospital for weeks getting this chemotherapy. He also had surgery. But after the surgery and getting the chemotherapy, and he said, I hate everything about being this sick. But one guy has made this possible for me. So one medical student got fascinated with this case, and the two of them together learned about this rare disease. And so every day, this medical student would come and share with him what he had figured out about his illness. And so he wrote to me and he said, I'm writing to you even before I know that my memory will be back 100%. He said, I'm getting better, but I'm definitely not there. He said, but I just want you to know that I was cured by chemotherapy, but I was healed by my story. And I think that he's not alone. Patients are healed by their stories. And really, that is why they gave us the story in the first place. It's our job. Robert Smith, who writes a lot about these things and teaches a lot about the biopsychosocial model, says we cure disease with medication. Exactly what my patient said. We heal illnesses mainly through our words and the therapeutic relationship we establish with our patients. That's what we owe our patients. That's what patients deserve. And that's what we should work to make sure is happening. Thank you.
Thank you so much. This was wonderful. We have time just for probably a question or two, a quick question or two. And again, Lisa will be up outside signing books, and if you have a short question, you'd be able to answer.
That's about house?
As well.
Don't you want to know if Hugh Roy was really a jerk? Yes, sir.
There you go. Yeah. I'm Don Moore. I'm a chaplain here, and so I'm a non-medical physician in a way. But the one thing I was listening in behalf of my physician colleagues, and I heard you say how important it is to give the story back.
Hold the mic up.
Give the story back to the patient. How important that is. What I didn't hear, maybe you spoke to it, maybe very briefly, that some recommendations about how to do that, or maybe I'm missing something here. But
How to do it?
yes.
Well, I think that's a very good question, and I spend a lot of time teaching residents how to do this because I think it is important. I mean, I think, first of all, you have to know your patient at least a little bit. You have to know things like how much education do they have? How much do they understand? And the way you do that is you ask them first. You say, what do you understand about what's going on? That's a really, really important place to start, is where your patient is. And then you can judge from their answer sort of where they are in terms of their understanding, in terms of their health literacy, in terms of their education level, and also in terms of the kind of detail that they want to know. There are some people who can tell you every spick, every teeny-weeny detail about what is known so far. My husband, he does not know these things. There's nothing wrong with his education. He's a very smart guy. But if you ask him what's going on, I don't know, my knee hurts. And that will tell you something about the way he wants to get his information back as well. So I think that the patient will tell you how to give it back, but you have to be willing to listen.
Yes, and there's another mic over. It's coming to you. Please identify yourself.
I'm Leonore. I'm from occupational therapy. And I have a comment rather than a question. I think that physicians should take to heart that a lot of the other staff spends much more time with the patients, and patients will often reveal changes that they're experiencing that can be pretty key to their treatment.
Absolutely right. And I think one of the things that used to drive me nuts the most about House is how little regard he had for other people's observations and experiences. I see nurses, just in the hospital, nurses have saved more lives than I will ever save. You know why? Because they're there all the time. I see my patients, we have to make a point with our residents that they should see their patients 3 times each day. As a patient, I'm sure you think, I've only seen my patient 3 times. It's like Woody Allen in Sex. How often do you have sex? All the time, 3 times a week. Never 3 times a week. you know, from a resident's perspective, I see my patient all the time, 3 times a day. From a patient's perspective, I hardly ever see my doctor 3 times a day. I think that they spend much more time with other people, and we have to utilize that as a resource of important data. You're absolutely right.
Well, I wish we could spend more time with you, but our hour is up.
I'm sorry.
So I thank you, and I encourage all of you to come back next week